Now, what is the role of the various nerves, genitofemoral, ilioinguinal, etc.? Actually, there must be a correction in the key. The ilioinguinal supplies the internal oblique muscle, and if there is any paralysis, it will create the weakness of the conjoint tendon and it will enable the herniation to occur. I think we don't need a correction. Ilioinguinal can lead to abdominal wall weakness. What is the role of genitofemoral? Genitofemoral supplies mainly sensory innervation to the skin which is overlying the femoral triangle. Then what is the role of subcostal, doctor? Subcostal supplies external abdominal oblique muscle. So that is how we need to remember. Where are the Herring's bodies? Is an important question. Typically, the neurohypophysis, it contains the Herring bodies which are formed from the neuroectoderm as an extension of the developing diencephalon when the posterior pituitary forms. You know difference between anterior pituitary and posterior pituitary? Posterior pituitary does not produce anything, it only stores the ADH, oxytocin, which are originally produced by the hypothalamus. That's the reason these Herring's bodies are basically the derivatives of the neurohypophysis is what need to be understood. Shoot me an answer. Von Willebrand's disease. Von Willebrand's disease. If there are bleeding episodes, how do you treat it? If there is a uncontrolled menorrhagia, how do you want to treat? If there are bleeding episodes, what do you want to inject to the patient? Or inject or make him swallow? Tablet or injection, no problem. Give me the correct answer. Very good. Desmopressin is a very good answer. So Dr. Amit made a very good guess of tranexamic acid. And Dr. Vidya also agrees with tranexamic acid, but you can remember, if there is a menorrhagia in von Willebrand, OCPs are indicated. And bleeding episodes are very well treated with vasopressin, DDAVP is what you have to fundamentally remember. It is the posterior cerebral artery which will be supplying the occipital lobes where our visual cortex is located is what you have to remember. What is the difference between salivary secretion and pancreatic secretion, doctor? Just while we conduct the discussion only, you make note of question numbers where probably we may be wrong. We can be wrong, let us agree. Around 8 to 10 questions may go wrong. It's a disclaimer we want to say. Because almost every Wednesday, Sunday, 240 questions to set up and host it and then deliver a question paper. NEET is tough even for teacher also. About 200 questions, we can be little careful. 30-40 questions, we'll try to pick up from the earlier question bank. During the picking process, 8 to 10 questions go heavy. So that's the reason, just agree with us the fact that in such a short time, we are able to conduct 2 papers every week. Along with the discussion itself is creating some tough task, though it is not a justification for the mistake. But you can always correct at the end of the test, you can always correct the mistakes. Now doctor, Mallory body, how is it basically formed? Mallory body derives from the keratin intermediate filaments within the hepatocytes. Where do you find Mallory body? Alcoholic liver disease. Anterior cerebral artery, remember doctor, all our muscle power is basically by MCA, that is middle cerebral artery. All our balance, everything is due to posterior cerebral artery. but still posterior cerebral artery supplies cerebral peduncles. Sometimes posterior cerebral artery can lead to hemiparesis. But what is speciality of anterior cerebral artery occlusion? It is not like MCA which causes hemiplegia. ACA strokes will lead to single lower limb monoparesis. Nothing else is involved. Everywhere power is okay. Only one lower limb monoparesis, because only the lower limb on one side is supplied by the anterior cerebral artery. Right? So, upper part of the precentral gyrus where the leg region is represented, and the upper part of the somatosensory cortex and the medial aspect of the frontal lobe, they are all basically by the anterior cerebral artery is what need to be remembered. Lateral geniculate nucleus of the thalamus. Typically there is yes, I think students still have some doubt on abdominal wall question. We will pick up for a debate. I think there two answers may be true. That is both the, we will take up. It may be one out of those 10 pardonable questions. More than 10 mistakes are there in the key, it is better to ban the question paper. So, probably that question requires some correction. I will take it up at the end of the session. Please bear with me. Now, lateral geniculate nucleus of the thalamus, where it can become involved. Remember, doctor, thalamus is the area where we get all our sensory input. So, if there is any posterior cerebral artery stroke, posterior half of the thalamus get involved along with the medial geniculate and the lateral geniculate body is what you have to basically remember. That's the reason when there is a thalamic syndrome, it is called as. How will the patient will suffer if there is a posterior cerebral artery stroke and thalamic syndrome? Entire one half of the body, patient will have severe pain. As such, the flesh is torn out of the body. It's called thalamic syndrome, because thalamus is mainly the blood supply. Posterior half is basically from the PCA stroke is what need to be remembered. Now coming to the choroid plexus, it is missing in the floor of the third ventricle, but otherwise in all the other parts we find some small amount of choroid plexus which contains the pile capillaries covered by the ependymal cells is what need to be remembered. Now shoot me an answer, doctor. Sentinel loop, colon cutoff sign, where do you see? And chain of lakes on CT scan, where do you see? Excellent. So we have acute pancreatitis where we see colon cutoff, and chain of lakes is typically seen in chronic pancreatitis. Dr. Anuja from Anantapur, Dr. Siri said carcinoma pancreas, but it is pancreatitis which is much more important to be considered. Now doctor, juxtaglomerular apparatus, when will it produce renin? When we are dehydrated, when the amount of blood flow, renal plasma flow is low, when the afferent arteriolar pressure is low, that is a stimulus for the juxtaglomerular apparatus. Any increased pressure in afferent arteriole to the kidney means that already we have sufficient fluid in our body. We don't want renin-angiotensin aldosterone for retaining fluid there. So that's the reason increased pressure will inhibit the release of the renin is what you need to fundamentally remember. How does aldosterone basically function? You all know, I think easiest question. Sodium permeability, it will increase in the distal tubule, which is the underlying mechanism. Now doctor, the reabsorption of the sodium and chloride in some parts of the nephron is non-neutral. That means more positive charges than the negative charges, or more negative charges than positive charges will get transferred. But there are some areas where it is electrically neutral. As many positive charges are traveling, that many negative charges are also traveling. Where do you see that? We see it in proximal tubule. Whereas how about the cortical and medullary collecting ducts, doctor? In them the diffusion of the sodium occurs through the channels of apical surface without concomitant chloride. Hence it will typically produce a electrogenic potential is what need to be remembered. Then how about the ascending limb of loop of Henle? In this also 1 sodium, 1 potassium and 2 chlorides will travel. Hence it is also electrically neutral. But we don't have ascending limb given among the options, is it? The thick ascending, that is, not thin ascending. So thick ascending also electrically neutral transfer of the sodium and chloride is what need to be remembered. Nephron physiology, doctor. One question invariably comes: what percentage of bicarbonate is reabsorbed in the proximal tubule? What is countercurrent mechanisms? All those things of the nephron physiology you have to be very sure. Now coming to the afferent arteriole in the glomerulus, if the resistance in that has decreased, इसका मतलब क्या है? Typically resistance decreased means flow increased. Increased flow into the afferent arteriole will inhibit the release of the renin, as we already have discussed it quite clearly. Now coming to the proximal tubule, wood substance will be more concentrated at the end of the proximal tubule is a very, very important question. Let us look into it. If you look at the sodium, sodium is isoosmotically reabsorbed. When the sodium is reabsorbed, water will also flow, so that the osmolarity is maintained constant. But the creatinine is not reabsorbed in the proximal tubule, but already water got reabsorbed along with the sodium. Hence what happens to creatinine concentration typically in the proximal tubule? The concentration will increase. Creatinine concentration increases in the case of the proximal tubule is what need to be remembered.